Welcome. My name is Ken Newell, a member of the AST Planning Committee. At the start of any new year, it's only natural that we focus on health and fitness. This year's no exception, and perhaps with the COVID pandemic, it's even more important that we focus on our health. The AST, in partnership with Veloxis, is launching its premier 2021 AST Virtual Run and Fitness Challenge, beginning now through May 21st. You can visit the website shown on the slide, check your email for updates, or stop by the Veloxis booth to find out more. With no further ado, I would like to introduce this satellite symposia entitled Caring for Renal Transplant Recipients During the COVID-19 Pandemic and Beyond, which is presented by Veloxis. Please stay tuned after the session for the panel discussion. If you would like to submit a question directly to the moderators, please use the Q&A feature on the side panel of your screen. Enjoy the session.
Hello, everyone. I am Dr. Dan Brennan, the Medical Director of the Comprehensive Transplant Center at Johns Hopkins, and I welcome you to this interactive webinar. I believe this webinar is especially relevant for all of us in the COVID era and moving forward. The webinar will be presented by myself and three other distinguished speakers. Dr. Patricia West-Thielke is a PharmD and the Director of Clinical Research at the University of Illinois in Chicago, as well as Research Assistant Professor of Surgery and Clinical Assistant Professor of Pharmacy. Dr. Rupi Sodhi is a transplant nephrologist and Assistant Professor of Medicine at Loyola University Medical Center in Maywood, Illinois. Dr. Dan Felix is a PharmD and clinical pharmacist at the University of Wisconsin in Madison, Wisconsin. Before we begin, I need to disclose that we have received compensation from Veloxis Pharmaceuticals in the form of honoraria and/or compensation for consulting. While these slides have been developed in collaboration with Veloxis, any clinical judgments or opinions that we express are our own. Thank you. Next slide. Patient renal allograft survival have drastically improved over the past 50 years. Let's take a look at this timeline. Next slide. So, first in 1954 was the first successful transplant at the Brigham and Women's Hospital between identical twins, the Herrick brothers. It was in the 60s that really Sir Roy Kahn with Gertrude Elliott and Hitchings brought azathioprine to us and then steroids. There was a major breakthrough in the late 1970s with the introduction of cyclosporin, then tacrolimus, and then mycophenolate later in the 1980s. But even with corticosteroids and the calcineurin inhibitors, rejection rates were still quite high, ranging 35 to 50%. It was in 1984 that the tacrolimus was arrived. And then in 1995, the MMF. 1999 was the approval of sirolimus, rabbit antithymocyte globulin in most of the countries in the world, not approved for induction in the United States until much later. And then new drugs have developed, and then the COVID-19 pandemic started. Next slide. So what other important things, in addition to the drugs that were introduced, were we developed new techniques to assess for antibody incompatibility with better tests for donor-specific antibodies and to figure out how we might try to desensitize people. But what most people have realized that did not work so well, and it is better to run around Mother Nature than run over Mother Nature, and most programs are involved in kidney paired exchange programs. Then there was the use of the marginal kidney donor, no longer termed that, and now we use the KDPI. Next slide. So what people don't realize is there has been over a 50% acute reduction in the acute rejection rates between 1995 and 2000. What people further don't realize is that there has been a remarkable improvement in the half-lives of kidney transplants associated with that reduction in the rejection rate, but also probably with the better management of the medical complications of transplantation, which are long-term. Next slide. In the time of COVID, though, we have a new way of looking at our lives, not only our personal lives, but the lives of our patients as well. This shows a little bit of the timeline of COVID in the United States. The first case was in January 21 in the state of Washington. And then in March, the WHO declared COVID a pandemic. By March 17th, St. Patrick's Day, CMS expands the telehealth rules to allow us to be able to treat people and see people through telehealth. On July 14th, Bastille Day, phase 1 and 2 trials demonstrated the efficacy of the Moderna vaccine. It's important to keep history in mind here as these landmarks occur. In late July, phase 3 trials began. That's fast. And then in November 22nd, the FDA approved remdesivir as a first drug. Now, sort of approved it. It approved it as an EUA, so an emergency use agent or agreement. And in December, FDA approved the rollout of the Moderna and the Pfizer vaccines. So how has COVID-19 impacted care of kidney transplants today? Next slide. Well, there are guidelines that have been developed, and these guidelines have been developed through multiple societies, and at the end we have a reference to the societies and groups that have been so helpful. The CDC Advisory Committee on the Immunization Practices are considering selected groups for early vaccination in a phased distribution. So as you know, phase 1A involved healthcare personnel and long-term care facility residents. Phase 1B was essential workers. And the essential is up to the definitions of the states. And phase 1C was adults with high-risk medical conditions. And most people consider transplant patients, by dint of their being on immunosuppression, to be people at high risk for severe COVID-19 due to underlying medical conditions. There's a push for dialysis patients to be considered as well. And I wonder whether any solid organ transplant, potential solid organ transplant recipient. And the reason for that is the COVID vaccine now has just been administered to about 3,000 or so transplant patients, and the early data are available. So what is our view on current vaccination guidelines for transplant recipients? Well, my view is that, yes, everyone should get them. But the problem is there's concern about the efficacy of the COVID-19 vaccines in the transplant population. And work done at Johns Hopkins, spearheaded by Brian Boyarsky, Robin Avery, Jacqueline Garanzik-Wong, and Dori Segev, they just gave us a presentation to our Comprehensive Transplant Center. And unfortunately, it looks like patients who are on antimetabolites are much, much, much less likely to develop antibodies after vaccination. How much less likely? Whereas you've read in the paper, there are antibody developments in 65, 85, 95%, 100% of non-immunosuppressed patients. If you're on an antimetabolite, it's less than 20%. So we have some work to do. Next slide. So I'm going to turn this over now to Patty West-Tilke. Patty?
Thank you, Dan. Thank you for that excellent review of the last year or so with regards to the pandemic and the excellent history of transplantation. So I think we're going to, obviously focus on what's been going on over the last year. And what the other speakers and I would like to do now is take everyone on the journey of the life of a transplant patient during this pandemic. So we're going to follow John. John is, we're going to meet John. John was on dialysis for about 3.5 years coming into the pandemic. He was cleared to join the wait list. approximately 2.5 years prior to that. And we're going to now walk through the life of John over the last year or so. So let's learn a little bit more about John. So John is a 66-year-old African-American male with diabetic nephropathy. His personal background, he's a full-time rideshare driver. His wife, Janet, works a manufacturing job. So his medical history is he was diagnosed with type 2 diabetes in his 30s. We know a little bit about how his diabetes was managed. And so his last A1C was around 9. He struggled to reach his goal level of around 7. His eGFR declined pretty consistently over the years. And as I said, he started dialysis about 3.5 years ago. So now, why don't we talk a little bit about the risk factors that John has with regards to his graft function and survival, and what would be relevant to his management. So Dr. Sodi, I was wondering if you'd like to comment on how you would manage, or what risk factors would jump out at you in your practice.
Sure. Thank you, Patty. So I think with this particular patient, there's a few things that jump out. Number one, his age. He's 66 years old. If my parents heard that I'd call someone 66 years older, they would be mad at me. But immunologically, they're a little older. So we do want to be mindful of that and their ability to handle immunosuppression, their infectious risk. Also, 66 looks different in a lot of people. It varies. So frailty comes to mind. An ability to handle the surgery and the medications afterwards. Additionally, he's had diabetes for over 30 years, so that comes with a lot of complications, vascular issues, as well as cardiac issues. So you'd want to make sure he was strong enough for the surgery and that he had the vasculature that could handle an allograft. With regards to the diabetes itself, it's looking like maybe he has some issues with blood sugar control. Certainly being on dialysis with a blood sugar or a A1C of 9% could certainly point to the fact that he either has a good deal of insulin resistance, or maybe he's not compliant with his diet and or his insulin regimen. That's a little higher than we'd like to see it for a dialysis patient. Being of African-American race certainly puts him at other risk factors, including increased risk of rejection, and there's infectious risk that comes with that as well. And certainly there is a study going on right now, which I think Dr. Brennan can probably expound on, that is looking at African-American race and risk factors associated with that in transplantation.
Thank you, Rupi. Yes. Dan, would you like to expand a little bit on the African-American race?
Sure. So the NIH is sponsoring the Apollo study, Dr. Newell. It's looking at the effect of the ApoL1 gene, which is present in one kidney risk allele is present in about 35% of African Americans, and 2 kidney risk alleles are present in about 13% of African Americans. And having 2 risk alleles puts the person at risk, greater risk for developing end-stage renal disease from hypertension, FSGS, HIVAN. And what the NIH is looking is at the role of getting a kidney from someone with 0, 1, or 2 of these risk alleles. Because it looks like ApoL1 involves chloride channels and a whole lot of different things. And so it is involving every single transplant center in the country, 268 of them, every single OPO in the country, and all the HLA labs. So this is a tremendous a collaborative effort cross-transplantation to try and figure this out.
Thank you very much for that explanation. So now that we have identified, what we see as the kind of biggest risk factors for John, now let's move along in his journey. So January 2020, rewind to, last year when some of us were in Miami for a meeting, John gets a new kidney. And so he gets started on maintenance immunosuppression. And then we see on this slide, we see specifically, he comments about a month after transplant, he's feeling better. We see some good labs. But let's take a deeper look into his maintenance immunosuppression and what was started and how we would maybe change that in certain situations. So this slide summarizes what he was started on. So he was started on immediate release TAC, 10 milligrams every 12 hours, Myfortic 720 twice daily, a prednisone taper. He's got his long and short acting insulin, Bactrim and Valcyte. So why don't we talk a little bit more about how we would individualize maintenance immunosuppression regimens. Dr. Felix, would you like to expand on this one?
Definitely. Thank you, Dr. West-Dilke. And this is something that, we could talk for quite a bit, but to kind of quickly summarize it, I noticed that specifically for John, he's on a higher tacrolimus requirement. I wonder if he's able to maintain consistent levels with his high dosing requirement. Potentially, if he had some adherence issues prior to transplant, seeing if he's continuing to have those issues, and I could consider potentially switching him to a once-a-day long-acting product to see if that could potentially help with any variability in his levels. And it does come back to the patient, what comorbidities they have, what drug interactions they have, what side effects they're having to these medications. With John's history of diabetes, I would consider potentially seeing if he's a candidate for withdrawing steroids or for tapering the steroids a little bit faster. Tacrolimus does have a higher incidence of new onset diabetes after transplant, seeing with his age if he's a candidate for maybe a co-stimulation inhibitor as well, due to its lower incidence of diabetes. But again, it's working with your patients. It's kind of looking at all their different factors that they have, and then tailoring what immunosuppressants would work out best for their whole picture. Of course, we have protocols and guidelines that we follow, but it's really listening to our patients and seeing how they're tolerating these medications that is kind of the art of transplant immunosuppression.
Thank you, Dan. And then why don't we flip over to our other Dan in the group. Dr. Brennan, would you like to comment on maybe how you would have individualized his immunosuppression with the upcoming pandemic he's about to go through?
Sure. Looking at John, there's a couple things that speak to me, and Dr. Felix has described some of them. That's a large dose of tacrolimus, suggesting that he could be a rapid metabolizer, which isn't surprising because just as the ApoL1 gene is found in the African-American population, the CYP3A5 star1, we should have paid more attention to my pharmacology class in med school. But at any rate, we're learning now about this. And you can tell that he's probably a rapid metabolizer because if you take his total daily dose of 20 milligrams, 10 plus 10, and divide that by what his level probably is, let's take 5 because I can divide 20 by 5 easily, and you get a ratio of 4. And if the ratio is above 1.5, that pretty much suggests he is a rapid metabolizer and at risk for having rejection and having interstitial fibrosis and tubular atrophy on biopsies by a year. And so he is on a large dose of Myfortic for someone on tacrolimus. Tacrolimus, Myfortic or MMF was originally approved with cyclosporin, which lowers the exposure. But that might be appropriate for him because he is a rapid metabolizer. And that's also a fair amount of insulin as well. We can get an idea of what his GFR is too, because he's on a single strength Bactrim and Valcyte of 450 milligrams daily. So I would guess his GFR is probably below 60 with those dose reductions. In the pandemic, what would I do? Well, I would pay attention to the absolute lymphocyte count. I would anyways. And if it's below 1,000, that would tell me that I should probably reduce the antimetabolite. If it were below 700, I should probably hold it because that's a risk for developing CMV, another virus, and I think by extension, maybe COVID.
Thank you, Dan. And I think as we're going to see, some of you've made some predictions for poor old John as he travels through this year. So let's move along. So now we've gotten to about 2.5 months post-transplant, and John starts having some issues. So he's complaining in the morning. He doesn't feel like he's all there. He feels like he's getting headaches all the time. His labs still look pretty good. His creatinine is 1.2, and his TAC trough is a little high. It's we're in this situation, we're looking at a goal of 5 to 7. So he has a trough around 9. But he's definitely complaining. So we have some more complaints on this slide. He feels like the medications affect him physically. They don't sit well in his stomach. So we have some issues that are coming up, and we typically see this at about 2.5 months post-transplant. We commonly see our patients start complaining about some of the different adverse effects with our meds. So Dr. Sodhi, would you like to comment on what you typically see your patients start complaining about around this time?
Sure. Yeah, this is exactly right. This is sort of the time 2.5 months out where the honeymoon period from being dialysis free starts to wear off, and they really start to become aware of their bodies and how their bodies are handling a new kidney and some of these new medications. Dr. Brennan alluded to the fact that he's probably a rapid metabolizer. So my suspicion is maybe his tacrolimus dose was really ratcheted up to try to get him to therapeutic trough levels. And so it's not surprising that maybe he's complaining of headaches and just some weird overall body discomfort, which can be associated with rapid metabolizers because of the pharmacokinetic profile of the drug. As well as, one of his complaints was things not sitting well in his stomach. That's pretty typical of patients on mycophenolic acid or mycophenolate mofetil. I think he's on Myfortic in this picture. So that could be upsetting his stomach. Just having symptoms come and go at different times of days. And some of that can be centered around when they take their medications. Certainly with his tacrolimus trough being high on the higher end of his goal, that's certainly a consideration. And then these high blood sugars that he's having are typically what we see. So as we all know, patients, as they get toward end stage kidney disease and even go on dialysis, their insulin requirements tend to come down. Some patients come completely off insulin, and then we give them a new kidney and a lot of steroid at the time of transplant, and some of them remain on prednisone, and that can drive up their blood sugars. And a lot of times they get stuck in limbo with what to do with their blood sugars, because no one's really sure who's supposed to be managing this. And he's already on quite a bit of insulin at this time. So this is pretty typical of what we see. Other things that tend to pop up at this time, not so much for him because he's over the age of 65, but people who are under 65 dealing with some of these feelings and then wanting to go back to work, or feeling financial pressure to go back to work. These are things that we see oftentimes come up right around the 2.5 to 3 month period.
Yeah, I would agree with you 100%. And this is, obviously something we would typically see. We'd have to make a lot of adjustments to the meds during the first, several months, which sometimes is very confusing to patients. They're trying to get back to what they thought was going to be back to their real life, and there's still a lot going on, and that adjustment isn't always easy for our patients. So let's see what the team does. So the team basically does a dose reduction and adjusts his diabetes meds. So very similar to what Dr. Sodhi had mentioned. And in general, most people believe that a lot of the side effects associated with the tacrolimus are related to peak levels. So dose reduction is a very common tactic. All right, so the team continues to try, but they're having some issues. So as Dr. Brennan mentioned, he's a rapid metabolizer, and they're having issues getting the level into his target trough. So there's been a lot of changes to his meds. His symptoms continue to persist. So he feels a little better, but not much better. So And now we're in April of 2020. And Dr. Felix, would you like to comment on some of the things that were going on around this time that maybe factored into John's team making some decisions?
Yes. So unfortunately, we were dealing with, the beginnings of the pandemic. We were a month after the WHO declared a pandemic in March. And to kind of top it all off, we had a tacrolimus shortage, which definitely kind of added insult to injury here. And it was a challenge that we were not expecting, but one that we definitely had to handle and manage for our patients. And it started with there being a shortage in the raw materials that were needed to make the drug tacrolimus. A lot of the generic manufacturers, unfortunately, did not have enough on hand. So we were finding pharmacies nationwide, ranging from local pharmacies to national chains and mail order pharmacies, kind of exhausting their generic products. Many patients were having trouble finding it, and when they were able to find it, their generic manufacturers were changing frequently, and this led to some issues with maintaining consistent drug levels as well. One of the strategies that we utilized was switching to branded products. We found that the brand manufacturers had a better supply of the product, so switching patients over kind of ensured that they were able to find the product a little bit more easily. In addition, with using a branded product, they're able to kind of stay on a consistent manufacturer, which would also lead to more consistent levels as well. So that was one of the strategies that we employed. Of course, sometimes our hands are tied based off of what patients' insurances approve or pay for. So that did also add some challenges to it. But a lot of times it was literally calling up pharmacies asking, what do you have on hand? What do you have in stock? Can my patient get to it? Can you mail it to my patient? And that's kind of how we muddled through those waters.
Yeah, for sure. I know at this time, I remember it quite distinctly. I was very involved with the transplant pharmacy community of practice, and we put together a very highly used document regarding medication shortages and methods for everyone to deal with what was going on in the pandemic. That was a very rapidly changing document at the time, because we were, there was the tax shortage, but there were other shortages too related to medications being bought up quickly due to potential efficacy for COVID. So there was a lot going on in April of 2020. So Dr. Brennan, do you want to comment a little bit more on some of the key challenges with managing immunosuppression during the pandemic?
Yeah, so another thing that's come up with this is, and like you said, Patty, this is changing so much. And I really am thankful to the AST and other societies for their guidelines, because I have to look at them and remind where we're at. One of the things that's come up is, should dialysis patients be vaccinated? And I think, yeah, absolutely, that makes sense. For them to be vaccinated. I mentioned that the vaccination response in terms of antibody development was in this early study by the group at Hopkins. Remember, first of all, that the antibody is a surrogate, and we use antibody when we look at mumps, measles, and rubella, sure, but it's really the T cell response that controls most viruses. And the antibody has a role. Thus, we use convalescent plasma, or we use bamlanivimab as a monoclonal antibody to treat COVID. In terms of someone who is, say, a donor, that also comes up for us. Should they be vaccinated? And currently, yeah, we think the donors should be vaccinated and get it whenever you can. Should you delay the patient receiving a transplant? We don't really think so, but by the Infectious Disease Society of America says maybe for a little bit. What about a second dose? Can they get that? What about the recipient who has just received a kidney transplant? And when should they get it? Well, the current recommendations used to be, say, for flu or something like that we would wait 90 days. That was based on kind of old immunosuppression when we had prednisone that was still 20 milligrams or more. And it was a different era. So I think that now the recommendations maybe delay till 4 weeks, and when they're off. I think I would follow the anti-lymphocyte count to try to give me a concept about what it's doing. But this study that's being done at Hopkins, and now there needs to be more work to figure out whether there is a cellular response that might actually be able to provide the protection. So it's fast changing.
Yeah, I agree. And I know, Dan, because you and I go way back, you have some predispositions to azathioprine. Did you want to comment at all about that versus mycophenolate with regards to the pandemic?
So there's only one person, I think, in the United States that still uses azathioprine, and he's talking. So, when I say anti-metabolite, there's not a lot of azathioprine that's in that bucket in the response to this. So I think that the studies have shown that azathioprine is effective. The later studies, when you're using it with tacrolimus as opposed when it was originally compared with MMF against Sandimmune, kind of an inferior cyclosporin product. So but regarding COVID, I can't really say anything.
Yeah, no, we definitely need more data, but I figured you'd want to talk about it. So, all right, let's move along and see how John's doing. So his meds did get adjusted, and they did put him on a once daily formulation. And so that went pretty well. But unfortunately, we lost him a little bit. So he starts missing some appointments in the summer. So June, July, something's going on. And then his nurse finally needs to reach out to him in August to get him to come in for an appointment. And what we see on his labs is not good news. So his creatinine has bumped up, and his trough level is now below therapeutic range. We delve in a little bit more. We ask him some questions, and we find out that his wife got COVID, and she was in the hospital, and he was very busy taking care of her. And he got very scared about COVID, which probably caused him to maybe not want to come in, which we saw quite a bit of. So why don't we talk a little bit more about, some of the questions that come up with what has happened to him over the last several months. So how might the knowledge that John's wife has COVID impact your care for John? Dr. Sodi, did you want to take this one?
Sure. So this was a pretty common tale to see, especially after we kind of got through the first wave. I think it's sort of a transplant physician's biggest fear is that your patient calls and says that their person that they're living with or the people that they're living with have gotten COVID, and a lot of thoughts run through your head. How do you keep patients safe? How do you keep your staff safe? How do you keep your hospital safe? And there's a decision tree that felt like it was changing about every 6 hours at that time during 2020. It depended on the hospital. With John specifically, there are some risk factors, high risk factors for rejection, right? So he's missing some meds, probably. He sorts of alludes to it. The creatinine's going up, his TAC trough is subtherapeutic, and he's kind of alluding to the fact that he's been tending to his wife. So the thought runs through your head that he may be missing doses of his medications. So, you can try to do lab work, but the problem is, where do you send a patient who has a potential COVID exposure? So there's a lot of logistic things that go on with patients like this. It depended on the hospital. At our hospital at Loyola, we could have patients that were exposed as long as they were masked and had a clean COVID test come in. Most of the time, though, we told patients, because we really didn't know the efficacy of the test, to stay home for 14 days, quarantine, and make sure that they were safe before they came out and exposed potentially anyone. There were options as far as labs that were being offered throughout the country. There were things like mobile phlebotomy and other things. And our center didn't use it, but I think one of the other panelists can probably expound on that a little more. Follow up with these patients was tough. Dr. Brennan alluded to earlier in the session that telehealth visits were approved by Medicare for appropriate follow-up for patients. We certainly at Loyola used that as a modality, but that presented its own challenges as well. People didn't, a lot of patients, depending on where they came from or what population you're serving, they don't have access to computers. They don't, some people still don't have smartphones. Some people don't have good internet or Wi-Fi. So, you've got people that can't really video chat with you all that well. So I think at that time it was center specific how people were coming up with management of these patients. I think probably what most centers were doing was telling patients to quarantine for 14 days if they were asymptomatic, 14 days from the date of their last symptom if they were symptomatic, and then for this particular patient, you probably want to bring him in and get him a biopsy at some point. You can try to check non-invasive things in the meantime, like DSAs and other things. But again, that depends on their proximity to a lab, the lab's rules about bringing patients in who are living with an infected family member. So it definitely was very, very challenging.
Yeah, I agree. I think all the institutions had lots of issues with this. Patients were scared to come in. We weren't sure if they should come in. Lots of unanswered questions, especially in the summer. I think we figured out a lot more going into the fall and testing became more available. But the summer was kind of a tough time for all of us. Dr. Felix, would you like to comment on how your institution handled the situation?
Definitely. So similar to what Dr. Sodi had mentioned, it's a lot of virtual visits. I know from my practice, we were doing a lot of remote phone calls and video calls with patients rather than bringing them in to minimize their exposure. We were working on consolidating labs if possible for patients so that they wouldn't have to go to labs as frequently as well. Maybe extending weekly lab draws to every other week or monthly to minimize that. Counseling a lot of patients as well to kind of empower them to make them feel comfortable to go get labs also, because there was a fear with patients to go outside the home and go to a facility, reminding them to, wear masks, use good hand hygiene to minimize the risk for exposure and to maintain physical distancing from others when they're at the facilities. And then for certain patients, working with home health labs to see if they can get labs drawn at home for those who are extremely fearful or even, COVID positive, to see if they could get labs collected at home.
Yeah, I agree. The uptake of mobile phlebotomy definitely increased over the year as we became more comfortable with it. Dr. Brennan, do you want to add anything more with regards to the handling of this in your clinic?
Sure. Similar to what Dr. Sodi and Dr. Felix have said, we reduced the frequency of labs. We tried to use mobile phlebotomy. We did encounter some issues that I wouldn't have expected. One of them was that for instance, there's a national lab provider that requires that your BK sample be frozen. So that's not necessary. I don't know why they do that. It's not necessary, having done a lot of BK tests and studied it in the lab, but that was a rule. And so samples were being collected remotely, not frozen, and then not being run. So we had some people develop BK nephropathy, despite our best efforts to screen them and monitor them, because of the lab just wouldn't do that. So we were happy when a lot of the national providers then were able to develop scheduling and distancing so that the folks could come back into their labs and get their tests. So that was something that we hadn't anticipated. With the remote monitoring, what we discovered is that people weren't staying at home, okay? They might have been told to stay at home, but they weren't. And so the remote lab personnel would show up and no patient. So And this gives us some insight into and how we can manage our patients. The telehealth had its own challenges, right? Because we've talked about this on other fora. How do you take care of an out-of-state patient? How do you take care of a new patient by telehealth? And there were the legal aspects, in addition to the technical aspects of the systems that we were using. The legal aspects were, to me, the more concerning, and I think are even still very concerning moving forward.
That little uptick in BK must have driven you crazy.
It was awful. Embarrassing.
Surprised you're willing to mention it. All right, so let's move along and see what else is going on with John. So obviously we talked about his missed appointments and his missed doses. So he comments on questioning, and this is one of the things that Dr. Sodi mentioned. He mentions that he usually takes at least one dose a day, but I'm taking pills in the morning and a couple in the middle of the day and at night, so he can't always keep track. So there's definitely some non-adherence issues that we saw and that we always see. But obviously, with the pandemic, I think a lot of us had, we had pandemic brain on top of everything else going on. So missing some doses occasionally is definitely something that we saw in our patients, possibly even more frequently than we normally see it. So that brings us to a couple slides related to the non-adherence and telemedicine. So there was some excellent talks today in a couple of the different sessions related to adherence and adherence tools and monitoring. So Dr. Amaral and Dr. Verna both presented some interesting information with respect to adherence monitoring. And I think a lot of, because we've had to learn a lot more about what our patients can and can't do with respect to telemedicine and, working on making sure our patients all have access to the internet, those types of things. I think potentially we can really make some impact on adherence, hopefully in the future, because obviously a lot of what goes into monitoring adherence and improving adherence gets down to using remote technologies, using smartphones, things like that. So we did see, obviously, in John, some predictors for non-adherence. So he had some difficulty adhering to his medications. He expressed that. He had some adverse effects that he told us about. So that as well is a big predictor for non-adherence. And then he skipped all those appointments in the summer. So he definitely had some signs for non-adherence through his journey. And with respect to the telehealth concept, Dan obviously has touched on this already a little bit. This slide summarizes the changes that we saw in March or April of last year. And I think Dr. Sodi as well commented the uptake of telehealth and telemedicine in all of our institutions was quite significant. And there was actually an interesting slide Dr. Serper presented earlier today that lit up the country in blue as the country took up using telemedicine in our patients. So, but this slide summarizes the changes that occurred that allowed us to really increase the telemedicine for our patients. So why don't we talk a little bit more? I know we've already kind of touched on it, but I think it would be great for each of us to kind of delve in a little bit more as to how we incorporated telemedicine into our care for our patients, what issues we saw, how we overcame those, and what our plans are kind of going forward. So we'll just go through everybody this time for this topic. So Dr. Felix, would you like to start?
So we we, even before the pandemic, for the pharmacy staff specifically, were involved with telemedicine for some of our patients that we cared for. That's how we would follow up with our post-op patients for some of the clinical consults that we had as well, was via telemedicine. So we just continued that, but on a larger scale post-pandemic, where we converted everyone to phone calls and to video calls, due to, again, trying to minimize the number of patients coming into the clinic, and to also expedite, the time that patients were in clinic to minimize their exposure to both other patients and to staff. So we found that, if we could call the patients at home, it would be less time that they'd have to spend in clinic waiting for the pharmacist to come and see them. And a lot of the other ancillary staff also were doing more remote telemedicine calls for patients at home.
Yeah, we did. We obviously incorporated a lot of telehealth visits at my institution as well, particularly in the pre-transplant. We didn't want those patients coming in for those check-ins if we didn't need, for that workup if we didn't need to. What I found oftentimes, and this gets back to kind of some of the issues that I think we all came across, is just patients struggled with the technology. So really having a champion that would, chat with the patient beforehand, make sure they, had the app on their phone, knew how to open it, those types of things. It was quite important to have somebody that was really there to make sure the patient was ready for those calls. Obviously, a quick phone call, which is, something that we were doing pre-pandemic, is easy, but actually using a doximity or something like that, the patient needs a little more coaching. So having somebody to kind of walk them through that, we found quite helpful. Dr. Sodi, how'd you guys handle it at Loyola?
So we had similar issues. We had patients that had signed up for, what we call My Loyola, which is a My Chart sort of situation, but they had never really used it other than the day somebody in the hospital had walked them through signing up. We started with Doxy.me for our telehealth visits, and those seem to be relatively okay, because basically they get a text message and they click on the link in the text message and they're in the waiting room. That was relatively simple, easy to follow. We are on Epic at our hospital, and Epic came out with their own telehealth platform, which became quite challenging for a lot of our patients. The first time they used that platform, I think there's 6 or 7 screens where they have to enter their insurance information, their medication list, et cetera. A lot of our patients struggled with that, and we had to get a staff member, like you alluded to, Patty, to sort of a champion for them to sort of walk them through these things so that they can do it. There's, with telehealth, it's interesting. There's a little bit of a dichotomy that exists between what the hospital wants you to accomplish and versus what the medical providers want to accomplish during the visit. We're not as concerned that someone enters their insurance information. We just want to make sure our patients are okay, and that they're, for a patient like this whose labs are looking kind of funny and has sort of reported struggles at home, our focus is on that. We have come up with a lot of ways for people that just simply cannot do things through the channels that need to be done. We've come up with ways to do it. We've converted a lot to just phone-only visits. When we had patients that did test positive for COVID, we were very blessed. We have a fantastic team of nurse practitioners that devoted themselves to checking on our COVID patients. So they would track the patients that were testing positive, and those patients would be called 7 days a week by our APNs. And it would be a 5 or 6, 7 minute phone call where they would walk them through, how they were feeling, what their vital signs were doing, and then they would give them advice. If things looked like they were going south, they would tell them to get to the ER. In our clinics, we had to abide by the hospital rules for who could come up and not come up. So most of the time patients were getting their temperature screened and things. We bypassed our lab. We had our MAs drawing the blood in the rooms when the patients got up to their clinic appointments so that they could bypass the lab. We got very creative. We were very lucky. The hospital was quite supportive, and we had a good ancillary staff that was willing to participate in the care of these patients during a very scary time. I don't know that every hospital was fortunate enough to have that, but that's sort of the model that we followed at Loyola.
Yeah, it's an excellent model you guys had going on out there. So I think we had a little bit more of a dichotomy, as you mentioned. We had, a lot of us really wanted the telehealth to work, but then there were people that were very concerned about the billing aspect and making sure billing went through. So I think that all ended up getting worked out pretty well, but there was definitely people who thought that if we can get the patients in, we should get them in and do face-to-face visits and things like that. Whereas there was another group of us that thought, no, let's just make this telemedicine work. Let's keep pushing forward on this because that would be the safest for all of us. So there's definitely some couple different camps on that.
Yeah.
Dr. Brennan, how was telehealth handled for you guys?
So just a couple things kind of to add on to what everyone said. For me, as the medical director of the transplant center, well, it wasn't just about kidney transplant, it was about everything. So we came up with some other things to keep people from, say, the lung patients from having to come in for their scheduled bronchoscopies. The bronch lab wasn't open, so we used a lot of donor-derived cell-free DNA and then telemedicine. The heart patients could have used, donor-derived cell-free DNA. They weren't comfortable, still were monitoring them. The liver patients, they were doing better. Thought about telehealth and realized we've actually been doing telehealth for years and actually probably violating all kinds of laws. How many times have I called in a back for someone in a state in which I'm not licensed? Oh, I don't know. Hundreds, and but what became clear to me was our most disadvantaged people were being disadvantaged even further, and that we had a moral responsibility to see the patients, to get them in and see them face to face when they couldn't work the telehealth thing. Trying to convince people to follow that moral high ground, that was a challenge too that I didn't anticipate. It's just like, hey, you're a healthcare provider. When the AIDS crisis happened, you went and you saw these people. You had no idea what they had. You just took care of them. I mean, was there fear and trembling? Yeah. I mean, people, when this first started, there was a lot of fear. But I don't know. I felt it was the right thing to do, and I still think moving forward, we especially need to offer the face-to-face visits for those people who want it and those people who need it. Because what I've had a bunch of the telehealth visits, I've had to say, you can't do this. You just can't. So you live in town here, you got to come in. And so, and I think they actually like that.
Yeah, there's been quite a few surveys done. There's, definitely patients who really love and think telehealth is the way to go. And then there's patients that struggle. And unfortunately, sometimes that is our older population who struggles with dexterity, struggles with technology. And that's probably the population that we should try to figure it out for a little bit better so that they don't have to be coming in. But I think we've made a lot of progress in the area. And I mean, I think I'm hopeful, and I think we all are hopeful that the telehealth is going to continue long-term for the patients that want it and it works well for. So I think that's...
Where I think it will be particularly advantageous is we have a problem with long-term donor follow-up, right? I mean, the CMS wants us, UNOS wants us to have 85% follow-up at 1 year and 75 or something at 2 years, and we're all abysmal at it. So it would be great if it would be allowed telehealth, but if you have a donor that's living many, many states away, hundreds of miles, they don't want the expense of flying in to come and see us and the inconvenience. Telehealth I think will be really good for that.
Yeah, I agree. Dr. Felix, do you see telehealth continuing at the same rate at which it currently is at Wisconsin, or do you see it kind of trailing back to where it was once things move forward?
I think it's pretty similar to, or it's more definitely than what we started before the pandemic, but I think it'll hopefully continue. Like others have mentioned, there is an ease, especially when we have patients who live far away from our center. Madison covers a very large area, and we have patients who live 3, 4, 5 hours away. And And having those telehealth visits does facilitate and make it easier for those patients to kind of reach out to us, have visits with them. So I do believe that we're going to be continuing with telehealth at a larger scale than we did before, just because providers, staff, patients now do feel a little bit more comfortable with it, like has been mentioned. And I'm excited to kind of see the continued evolution as we continue to use telehealth going forward.
Yeah, I agree. I know one of the comments that really struck me early on when I was doing the telehealth with the pre-transplant patients is they just really felt like we were basically coming to them. We were coming into their house as opposed to making them drive down to, for these visits, oftentimes sitting in the waiting room for hours waiting, just talk to somebody. I think it just really, empowered the patient a bit more with respect to their care, because we were kind of giving them a little bit of the steering wheel. So I'm also hopeful that the telehealth will continue for the patients that want it and that it works for.
And one of the things that we noticed as calling a lot of our patients was that they would feel like we were sometimes the only contact that they had for the week. They were isolating, especially post-transplant. They had very little social contact. So I think they also got that social interaction out of it as well. And we would have some very colorful chats at times.
Yes. Yes, I agree. I reached out to several of my research patients multiple times during the pandemic, and I would get they were just so excited, you want to talk? Oh, I'll just call you. And I was like, oh no, it's just a text message actually, but sure. Feel free to call me. So yeah, I think there's a lot of aspects of the telehealth that we need to take into account going forward. Mainly just to, really help our patients who do travel far, like you mentioned. So a lot of us live in areas, or a lot of our patients live in areas where, if it takes them 2 or 3 hours to get to the center and then they're there for 30 minutes, you can see that becoming very frustrating for our patients. So. All right, so let's talk about John some more. So now we're about 9 months into the year, into his transplant, and the team starts talking about transferring him to his nephrologist. So, his primary team starts to, talk to him about this, and then they start connecting him with his nephrologist in the community. So why don't we go do, again, a little bit of a roundtable as to how we each handle this at our institutions. So Dan, I don't know, Dr. Felix, if you would like to start, then all the questions are on here, and we can each just kind of tackle the ones that we feel best suited for.
So I'll admit at the University of Wisconsin, we actually don't transition our patients to a local nephrologist or their primary nephrologist. We like to hold them tight and hold them close for the duration of their graft. So we do manage patients lifelong or for the duration of their graft. And I have very little experience with transitioning patients over.
Okay. Yeah. And I think as we're going to see here, each of our institutions handles this a little bit different. So Dr. Sodi, how does your Loyola handle transferring?
Well, I wish they would do what Wisconsin did, because I'm very OCD, and I really it hurts to let the patient go. Loyola will transition after a year, assuming that the patient is stable. So we wouldn't transfer a patient that was, at the year mark, but having an acute rejection or viremia or some other complication from transplant going on. I think in an ideal world, every center would keep their patients forever. I think from the healthcare provider standpoint, we all would feel more comfortable that way. But I think from your ancillary staff standpoint, they, that's asking a lot of the coordinators to just keep growing their patient list exponentially every year and putting all that burden on them. So I do kind of understand the thought process of transitioning out. with COVID-19, during the transition period, it was very tough. I think we pretty much didn't transfer anybody because a lot of physicians were not accepting new patients. A lot of physicians weren't seeing people, as Dr. Brennan alluded to earlier. So it was difficult at that time. We're sort of through, I think, the worst of it. So I think people are starting to transition back out. Bridging communication has been a challenge, and it's the reason I think at least every transplant nephrologist really hates letting their patients go, because, you have all your ducks sort of in a row. And if somebody leaves your line of sight, you don't know what's going on. And so, the way we tackle those issues, even in this case, if we look at early on when John was complaining that his blood sugars were high, it was the transplant team that was actually adjusting the insulin. And sometimes it's an easy fix, but most of the time, we aren't really endocrinologists or specialists at tackling diabetes. And thank God for our pharmacists, because they know a lot more about the drugs than we do at this point. And there's so many new ones out, even from when I got out of training, once a week injections, more oral options, et cetera, that I didn't use when I was a resident and a fellow. So I think it's really important to prep these patients on the pre-side for what's coming on the post-side and have those people in place so that when it is time to transition the patient out, they have the resources already in place. What you typically see for dialysis patients, and bless general nephrologists for doing this, is that the patients are tied up in dialysis 3 days a week, so it's hard for them to get to other appointments. So you find that a general nephrologist is typically managing the diabetes or the lupus, or even sometimes the hypertension, and sometimes even the coronary disease. Unless they're complaining of chest pain, they don't really follow regularly with the cardiologist. And so what happens is they get transplanted, and now this person that was taking care of 4 or 5 of their problems has now vanished from their medical team, at least acutely in the short term. So we try to advise patients and counsel patients on the importance of sort of following with specialists in the community, so that when they do transition over to a fresh transplant patient, that they have resources available to them. And they're already established, because what COVID has taught us is sometimes you can't just get an on-demand new patient visit with somebody whenever you want to. So that's kind of how we do it at Loyola.
Great, thank you for that. Dr. Brennan, do you want to comment on how your institution handles transplant to community care?
Sure, I have a little bit of a unique perspective, dealing with all of the solid organ.
I think we're gonna go to Dr. Sodhi, just because I think you're having some connection issues. So Dr. Sodhi, I know you touched on a lot of this, but this is kind of the meat slide for the transfer to community care. So if you want to kind of talk about this a little bit more, and then we'll move on.
Sure. Yeah. So again, as I mentioned before, so before transplant is really when you want to start thinking about these things, because what happens is after transplant, things happen, and nobody could have predicted a pandemic when we were all in Miami last year in January at ASTS. So I think things come up, and not only with a pandemic, but people's situations change. Sometimes somebody loses a job for whatever reason, their insurance changes, they can't get into providers. So you want to try to put, I think, as many tools in place prior to the transplant as you can. So think about what your wait time is, how much wait time the patient has, what your center's average wait time is. Sometimes people, if you're seeing them when they're only been on dialysis for 6 months and your center has a 5-year wait time, you can kind of let them stay status quo. But as they get toward that time where you see that they're probably going to start coming up for offers, you want to start implementing some of these tools in place. So for us, if we see somebody who's a diabetic, particularly like this patient who has kind of an erratic A1C, maybe not so great with diet, is on a decent amount of insulin in the beginning, you want to maybe get them to an endocrinologist and get them plugged in with somebody. And, once you get that person's name, send them a letter to say, we anticipate that this person may have some issues with hyperglycemia. Just want to make sure that you're aware immediately post-transplant. as far as, and that really encompasses sort of having a multidisciplinary approach to patient care. And you get them through that period of time, whatever it is, 1 year or 6 months, or some people it's like 3 months or a week. I even heard one time, I was like horrified, but they go back, and some places have really good relationships with the general nephrology community, and they can do that very easily. Sometimes in the smaller cities, it's a very, very simple transition, and there's a lot of communication open. I think during the transition, coming from St. Louis to Chicago, I realized how much bigger the city is and how far the patients come from. So I'm getting used to not knowing all of the community nephrologists. So it's really important when you're transitioning back to clearly define what the expectations are. So for example, if the patients are supposed to alternate visits, that needs to be communicated, because a lot of times what we see is they're supposed to be alternating visits and then they miss someone's visit. So now a patient who was supposed to be seen every 3 months goes 6 or 7 months without a visit or a labs. So I think as long as there's a lot of open communication as far as what is to happen during that time, I think that works really well. And the general nephrologists, I think, really appreciate some guidance as to what the expectations are from the transplant center. If there is an issue with immunosuppression, who's supposed to be, managing that? Are they supposed to be checking for things like BK and CMV, and at what frequency? So giving them a good summary of how their post-transplant course has gone and things to watch out for is great. And then again, long-term, just making sure that the expectations are quite clear about how often the patients are supposed to follow up, not only with the patient, but with your sharing provider. And some patients don't, or some centers don't alternate visits. They just send them out and say, if you have a problem, just send them back. And so sometimes it helps for general nephrologists to know how often they should be seeing these patients as they get further and further out from transplant. So I think collaboration, communication, and setting up a good team around the patient are pretty vital tools that you need in order to ensure long-term success for the patient.
Yeah, thank you, Dr. Suri. That was an excellent explanation of all of that. And I think I have heard a lot, pretty frequently that, once you send them out, they're gone. But the alternating visits, I think, is almost a better way to handle that, especially during the transition. I mean, maybe at some point you let them go, but I think I'm along the lines of you, as I'd rather we never let them go. But pulling the it's hard to let them go. Pulling the community nephrologist in and having more of a collaborative relationship is one way to tackle that, because then you're not 100% letting them go. You're just letting them go a little. So, Dan, good to have you back. Dr. Brennan, I think we were going to move on to the next topic, but I know we didn't let you finish because we had some internet issues. Was there anything that you wanted to add to this discussion?
I mean, with COVID, looking at the different organ transplants, the mortality was kind of highest in the people who are on more immune suppression, and also those who ended up being followed locally. So I think that when you have a stressed system, let's face it, none of us can do what we do without the teams that we have. And that's what we have. We have a team full of PharmDs, nurse practitioners, nurses, social workers, dietitians, etc. That's why we're good. So it's just really hard being, without all the resources that we have in our teams. So, and if anyone figures out transition, please let me know.
Yeah, it seems like there's no perfect way. So, but, all right, let's get back to John before we get cut off and we don't get to find out what's going on with him. So he does transition, and unfortunately that did not go well. So I think they did not find the perfect transition process. So he comes back about month 14, and now his creatinine is very elevated to 4.3. His tech's in our goal level, but he's definitely having some graft dysfunction. And unfortunately, Dr. Brennan alluded to this earlier, but we go ahead and get a biopsy. and he does develop some interstitial fibrosis and tubular atrophy that we see on the biopsy. So Dr. Brennan, do you want to kind of delve into this in our last few minutes? Specifically, what happened with John is he admits to non-adherence. He had some financial issues. He had to choose between immunosuppression and insulin. He chose his insulin. So how have financial situations impacted your patient's decision and your clinical decision making?
So they have for a long time, and I just hello to and kudos, congratulations to our societies and everyone for helping push through the long-term immunosuppressive bill that President Trump signed, because we've been trying for 20 years to get that done, and hopefully that will relieve that. I mean, I think Dan Felix knows, and he's the one who told me, but insulin costs about $500 a month. So that's $6,000 a year for insulin. So doing what we can to avoid diabetes would be a good idea. So yeah, it's a problem. I mean, if you can't afford medicines, that's clearly a big risk factor on top of all the things that he had as well, that he was a rapid metabolizer, you know, that by the way, that work on being a rapid metabolizer was done in Germany and in Norway. So not a very high African-American population. So it's not just in African Americans that are rapid metabolizers, but it puts you at risk. They did protocol biopsies, you know, at 1 week, 1 month, and a year, and they found the rapid metabolizers were to develop the rejection and the IFTA.
Thank you, Dan. Dr. Felix, do you want to comment on some of the patient programs that we have available to help our patients in these financial situations?
Most definitely. And it's definitely been even more challenging with the pandemic because unfortunately, similar to John, patients have lost their jobs, and with that does go their insurance and making their medications affordable. There are, you know, patient assistance programs that patients are eligible for if they meet certain financial cutoffs. We at the University of Wisconsin have a team of pharmacy technicians and nurses that work with patients to determine eligibility and sign up for those programs. There's also different drug coupons that we see if patients are eligible for as well. Unfortunately, a lot of the coupons do exclude patients that have government payers, such as Medicare Part D or Medicaid. So that does limit its applicability to a lot of our patients who do have those government payers. Other options are drug discount programs that we see if patients are willing to partake in, whether through national chains or even through national organizations. And we also work with patients to sometimes fundraise. That's one of the things that I know the social workers at the University of Wisconsin remind patients, you know, that unfortunately the medications can get costly and the cost of transplant can be heavy. So they do encourage patients, if possible, to fundraise with their families, friends, churches, local organizations to see if they can, you know, raise money to cover their medications, especially when they do have loss of employment and loss of insurance.
Thank you very much, Dan, for that explanation. And yeah, there's definitely lots of resources. And the ASD website actually has lots of links that can be very helpful as well. We are about to run out of time. So looking back, obviously, I think we've learned a little bit of things we could have maybe done a little bit differently for John. We discussed a lot of the issues that he faced. Obviously, it wasn't a straight path. He had lots of turns along the way, and his team helped him through. And we discussed a lot of the different issues that they had to face. There is one question that I'd like to get to. I think we addressed it a little bit, but one of the questions that came up from the audience, can Dr. Brennan give any additional information on the relative failure of transplant recipients on antimetabolites to develop antibody response to COVID vaccine and timing after vaccination and COVID epitope evaluated? I think we touched on this a bit, but I didn't know if Dr. Brennan, if you had anything else you wanted to add.
just briefly to say that, there's different antibody tests. There are two different antibody tests that were looked at in this study. So it depends on, it's complicated. Both were to the spike protein. I believe both were IgG for different companies that these were done. So that's what the preliminary results are. Again, that what it tells me is that doesn't mean to tell your patients not to get vaccinated, but the question was posed to me by Dr. Segev after this presentation, what would I do? And what I would said, if someone's going to get a vaccine, I check the ALC, reduce the antimetabolite per the guidelines that, by analogy, ALC less than 1,000, reduce the antimetabolite less than 700, stop it. And probably stop it for 2 weeks before the vaccine and then 6 weeks after the vaccine to allow for the body to mount an appropriate immune response. So I think that's safe and effective when you have a virus that is a sign of overimmune suppression, like CMV, BK, maybe EBV, and so that's what I would say. And then Dr. Maltzman, he's the T cell guy, so we need to look at what the T cell responses are, because they might be just perfectly fine. If you think how the antimetabolite works by blocking as an antimetabolite, blocking translation, that's probably why it's working the way it does.
Thank you, Dan. And I want to thank AST and Bilaxis for allowing the four of us to discuss all of our different viewpoints on the issues that we were able to go over with respect to the journey of John during the pandemic. And this last slide has some resources that we find helpful for everyone. And with that, we hope you enjoyed the presentation, and thank you very much.